Hello, everyone. Thank you all so much for joining us today. We're going to be getting started with the webinar shortly. But in the meantime, I'd love to tell you about some upcoming events. Our next California Labor Lab webinar will be on Wednesday, March 27th, and that'll be on workplace mental health, embracing a population health framework with Dr. Leslie Hammer. You can read more about upcoming webinars at calaborlab.ucsf.edu/webinars. And on behalf of the California Labor Lab, a NIOSH Center of Excellence for Total Worker Health, we're pleased to welcome you to today's webinar. Just a few housekeeping items before we get started. If you have a question, please enter it into the online Q&A box. The Q&A is a little bit different than the chat. There's a special button for the Q&A, and that just helps us keep better track of your questions to make sure we address them at the end of the presentation. We will be saving time at the end of the presentation to address as many questions as possible. This presentation is being recorded and will also be made available on the California Labor Lab and Center for Occupational and Environmental Health YouTube page within 5 business days. And all participants who logged in with their registration email for the full live presentation today will receive an email tomorrow with a link to the evaluation form that will qualify you for a certificate of completion with 1 continuing education contact hour. Once the evaluation is completed, you'll be able to access and print your certificate. And without further ado, it's my pleasure to hand it over to our moderator for today, Dr. Christina Banks.
Thanks, Michelle, and welcome everyone. I'm really looking forward to today's webinar. This will be presented by Dr. Peter Schnall, who is a personal friend, colleague, who I've known for many years, and he's worked tirelessly with his team on the Healthy Work campaign, and I'm very pleased to present this to you today. A few things before we start. We need to identify our disclaimer. So we'll advance the slide there. Just so you know, Total Worker Health is a registered trademark of the U.S. Department of Health and Human Services, and so on. Next slide. And the funding for this webinar is from NIOSH. We're part of the Total Worker Health program as the California Labor Laboratory. Next slide. The mission of the California Labor Laboratory is to extend the pursuit of health and safety for workers in traditional employment to those in a wide range of alternative arrangements in partnerships with affected communities. As Michelle mentioned, our next webinar is on Wednesday, March 27th, presented by our colleague, Leslie Hammer. And it'll be an extremely interesting webinar, and we hope you'll join us for that one as well. And then finally, we want to announce our 3rd annual virtual conference, which will happen on May 7 and 8 on the theme of modern work and worker voices. It is virtual, so you don't need to show up. You just need to plug in. And we're very excited about our 2-day conference, and we hope you'll join us then as well. So without further ado, let me begin with my introduction of Dr. Schnall. Dr. Schnall is co-director of the Healthy Work campaign, as well as the founder and director of the Center for Social Epidemiology. An internist and epidemiologist, Peter has been studying the impact of working conditions on the development of hypertension among workers for over 40 years, as well as promoting increasing awareness among students, colleagues, and the public of the important role of psychosocial work stressors play in the development of chronic mental and physical illnesses. Dr. Schnall leads the academic interdisciplinary research team that includes himself, Marnie Dobson, Paul Landsbergis, Karan Fagri, Ellen Roscom, David Legrand, Viviola Gomez-Ortiz, and Juan Gabriel Ocampo Palacio. Peter's role as co-director of the Healthy Work campaign includes supervising the Healthy Work campaign in collaboration with the Healthy Work campaign team, developing contacts and relationships with potential Healthy Work campaign partners, and as a writer of web pages, blogs, and other materials to promote the campaign. I will note that this presentation has been pre-recorded, but the Q&A at the end of this presentation is live, and Dr. Schnall is joining us from Bogota, Colombia. So please, again, enter your questions in the Q&A button on your screens. And with that, let me turn it over to Dr. Schnall.
Good lunchtime, everybody. Thank you very much for joining our presentation of the California Labor Lab. Today, February 28th, we're going to talk about work stressors and illness in the United States and our approach at the Center for Social Epidemiology to dealing with this problem through our Healthy Work campaign. So I'm going to describe both the setting for health and illness at the workplace and our interventions for doing something about it. So I don't believe I need to say to you more than once that there is a work stress epidemic going on in the United States, and that this has been exacerbated by COVID, but it's not entirely due to COVID, because things like exhaustion and reporting stress at work have been on the rise for 15, 20 years now, perhaps even longer, depending upon which surveys you look at. And we have now higher average stress levels in 2019, 20, 21, and 22 than we have had since 2007. And some 70 to 80% of working people who answer surveys say that they experience work-related stress during the month previous to the survey. And that 70% said that work was the top source of stress, along with deficiencies in money, and this has been increasingly higher. So what kind of things at work do we believe are causing work stressors that are significant for people to be paying attention to? Here is a graphic which highlights 4 of the most important stressors at work. On the upper left corner, the job strain model developed by Karasek, or sometimes called the demand control model, in which jobs that are highly demanding and low in control, what we call the high strain quadrant in the graph, are associated with various psychological stress outcomes as well as physical health outcomes, which we will discuss in a moment. And then another alternative model, high effort and low reward, has been shown to be independent of job strain, a cause of various health, mental and physical health outcomes. Work-life imbalance has been implicated in all this. Long work hours. The longer you work, the more hours you do, the higher your blood pressure and your stress levels go. And of course, workplace bullying, harassment, and discrimination are all items that contribute to people's mental health and negatively when they are present. These all can be changed because they're all built into the design of work. Here are some photographs showing, typical kinds of workplaces. We now know that stressful work can cause chronic disease. And this body of evidence includes both mental health outcomes as well as cardiovascular outcomes. It also contributes to acute injuries, diabetes, sickness, absence, disability, and disability pensions. Programs to improve work organization can potentially have benefits across a wide range of chronic diseases. And the evidence for this is quite extensive now. Here's a slide which basically shows 3 different health outcomes, CVD on the left, burnout, depression on the right. And you see that the psychosocial stressors contribute to each of these. Now, this shouldn't be terribly surprising to anyone because we know that psychosocial stressors cause mental health outcomes such as burnout and depression. And we know that burnout and depression is related to blood pressure, as well as to cardiovascular disease and heart attacks. So the fact that they have common stressors is a reflection of the fact that diseases have commonalities in which mental health problems are in fact contributing to physical health outcomes over a longer time period. So let's take a quick look at some of these models so that we familiarize ourselves with them. So here's the Karasik and Terrell job strain model, high demands to the right, low decision latitude or low control to the bottom. And we have a outcome, what we call job strain, people with high demands and low control. And this is a very strong risk factor, what we call an exposure variable for mental health outcomes such as burnout and depression, as well as for high blood pressure and heart attacks. We think of this as an exposure variable. Keep in mind that some psychologists consider job strain a psychological outcome, synonymous basically with being stressed. We talk about job strain as an exposure variable, not an outcome. And this confusion sometimes in the literature can, trip up people when they're reading and trying to understand what's going on. So, job strain, high demands and low control is a contributor and an important one to psychological disorders, cardiovascular diseases, including musculoskeletal disorders, and to depression and anxiety. And people who report job strain are more likely over their work lives to retire with disability pensions than people who don't report job strain. And this applies for women as well as for men. So here's a model which we have constructed to try and explain the relationship between stress at work, and cardiovascular disease. We have a number of papers on this topic that people can peruse. But sources of stress at work are associated with smoking, lack of exercise, heavy alcohol use, and overeating, which leads in turn to hypertension and obesity, separate from the psychosocial factors that we've been discussing, as well as burnout and depression, sleeping problems, etc. And all of this has been going on for 100 years now, where we find that in modern industrial society, there's rising prevalences of most of these unhealthy outcomes, diabetes, and obesity, and hypertension, as well as cigarette smoking. And they have occurred during a profound period of change in the history of the United States with increasing urbanization, industrialization, and policies in general that are promoting a global economy, such as deregulation and free trade and privatization. CVD and hypertension must be understood as epidemics of recent historical origin. They did not exist prior to modern industrial society. And this has been repeatedly demonstrated by many, many anthropologic studies of primitive cultures or different cultures of different makeup compared to urban industrial society. So, for example, here's work from Ingrid Waldron, a well-known biologist at the University of Pennsylvania, who has studied blood pressure among various different work cultures, from urban industrial all the ways to hunter-gatherers. And you see at the bottom of the slide that traditional cultures, agriculture, pastoral herders, hunter-gatherers, have blood pressures which are basically normal blood pressures, 120 systolic among 50 to 60-year-old men. Whereas the blood pressures on average, in industry in urban industrial cultures are almost 140 millimeters of mercury, which we would consider to be high blood pressure. So hypertension is a clearly growing global epidemic, which is associated with increased prevalence of hypertension, both in developed countries such as the Western countries, United States and Europe, as well as in developing countries, where over the course of the last quarter of a century, the number of people with high blood pressure, has increased dramatically from 640 million to over 1.5 billion people. And in the United States, despite all the efforts to treat hypertension, et cetera, the hypertension by age group continues to increase, so that 30-year-olds show increases in blood pressure, as well as higher levels for 50 and 60 and 70-year-olds, though those have now smoothed, evened out with increased treatment of hypertension. So that's lowered the blood pressures to some extent at the far upper right. So I want to share with you my contribution to this field, which began with my work in 1985 with Dr. Thomas Pickering at Cornell Weill Medical Center in New York City, where I was working on the idea of studying job strain, in working people. But I felt that we needed to have a measure of blood pressure that reflected what was going on at the workplace, as opposed to being in the blood pressure in a doctor's office, which is subject to numerous biases having to do with the environment of the doctor's office, including anxiety of the clients and patients who come there. So Dr. Pickering and I collaborated on the design of a NIH-funded study, initially a case control study, which was started in 1985, and then it transformed itself into a longitudinal study, which we were able to do 4 waves over the course of 16 years, from 1985 to 2000. And we began initially with 283 men at 8 large New York City work sites. And ultimately, when we added women and additional subjects, we had 472 subjects who were studied for 10 years. So here is some of the results for our job strain variable, high demand and low control, that we've been talking about. And you see here that for the men in the case control study, which is the red block on the graph, as well as at time 2, the blue block, that when they report being exposed to job strain, their blood pressures are some 7 to 8 millimeters higher at time 1 and 6.5 millimeters higher at time 2. And that this also holds up for diastolic blood pressure, higher at time 1 and time 2 if they report job strain. And since we were able to get funding for a longitudinal study, we then looked at men at both time 1 and time 2 as to whether or not exposure mattered. And we found that those people who told us at time 1 and time 2, exam 1 and 2, the 128.5 millimeter group here, gray box, had the lowest levels of blood pressure, systolic blood pressure, of all of the various groups. Whereas people who told us at time 1 and time 2 that they had exposure to job strain at both times were literally 11 millimeters higher, in their blood pressure, their systolic blood pressure, than people who were unexposed during the course of the study. And this is after controlling for a number of variables that we believe impact on blood pressure. So this finding is consistent across different measures of blood pressure, and you see basically that systolic blood pressure was higher among people with chronic job strain, the blue bar, both for systolic and for sleep blood pressure. Home and sleep blood pressures are all basically elevated by about 10 millimeters of mercury if you were chronically exposed to job strain. So what is the impact of all of this illness on the workplace? I mean, people obviously are getting sick. They take disability, they lose time from work because of all of these health outcomes associated with work stressors. And this is also reflected in the cost of businesses to doing business. We have many ways of measuring how companies are doing. And we, for example, can measure disability claims, which companies collect data on. Here's a paper from my colleague, Paul Landsbergis, who I've spent many happy and interesting hours studying cardiovascular disease with over the years. Here's evidence, okay, that high-risk facilities have more of these various health outcomes than facilities that are not at high risk. Overtime, for example, is related to more claims for hypertension and heart disease than workplaces that do not have a lot of overtime. So this data is used by companies basically to calculate their cost of these health outcomes, which the companies basically don't understand are related to the organization of work. That is, they assume that these are individual problems, that people develop problems of high blood pressure, but they're not work consequences. They're, whatever, eating consequences or unhealthy behavior consequences. But in fact, okay, both the individuals are suffering from these work stressors and companies are paying for these costs, are paying costs for these outcomes. Many international studies, okay, have looked at employees who work under pressure and find that in terms of work-related stress, that high demands, emotional demands, increase not only all these illnesses, but occupational accidents and injuries. And they impact on absenteeism from work, with hundreds of millions of people taking time off from work. Economists like Dr. Pfeffer report that the direct and indirect costs of work-related stress in the United States adds up to hundreds of billions of dollars per year. And he has written all of this up in a book called Dying for a Paycheck, which I recommend to people, and notes that the evidence suggests that there are almost 120,000 deaths per year due to these various causes of health outcomes that he shows are work-related from his analyses. So question is, well, given that we see that work is so toxic and that it's causing illness and it's costing businesses money, what can be done about work stress? And there are various models about intervention, okay? One traditional model that people talk about is whether or not you want to focus at the individual level. Level one would be prevent the stressor from occurring at all by obviously changing the workplace or changing society. Or the alternative is at level three is talking about focusing on the individual to prevent the stressor. Or to treat the stressor. And then countries have stress prevention policies, guidelines, standards, and law. But the one thing that is very striking about this is that despite the fact that countries in Asia, Europe, England, South America have laws and regulations and standards and require surveys and surveillance of work stressors, the US has no guidelines at all regarding work stress prevention or psychological health and safety. Now, some of these international standards are codified under ISO standard 45003. If you're interested in this topic, you should read some more about this. But there are other alternative strategies to just passing national legislation. Passing national legislation is very difficult to do because businesses don't necessarily share the perspective that sociologists and social scientists and epidemiologists have come to appreciate, which is that the workplace is a major cause of work stress and cause of health outcomes. So we have NIOSH trying to educate the public through their total worker health programs and their centers of excellence. We have many scientific colleagues doing work like we are, trying to understand what the relationships are between work stressors and health outcomes. Many trade unions involve themselves in collective bargaining to try and improve the workplace. And then some states, such as California, have passed legal laws, regulating work hours, trying to reduce the amount of work stress that the public is exposed to. And then we have our Healthy Work campaign, which I want to describe to you. And our mission in the Healthy Work campaign is to reduce work stressors, harmful work stressors, to improve job quality and health. And my co-director of the Healthy Work campaign is Dr. Marnie Dobson, who's been working with the Center for Social Epidemiology for almost 15 years now. So what is healthy work? I mean, what are we trying to achieve? What is the goal here? So here's a graphic which we have created for the public, for your use, that we think is important, and that is an attempt to educate everybody about what would healthy work look like. Okay, if we could have our dream jobs, what would they consist of? So here's a list, and I'm just going to mention a couple which I think are extremely important. Free from danger. Okay, so this is what the OSHA Act is all about. That the workplace should not expose people to injury, to chemicals, to dangerous equipment, etc. And it's been very effective in preventing occupational injuries from occurring since its passage in 1970. Over the course of 50 years, then the rate of work-related injuries has declined dramatically. But in addition to being concerned about physical injury and occupational health injuries, there are all of these psychological outcomes that are going on and demands that are being put on people. People are experiencing abuse at work. They are discriminated against. They're silenced and prevented from voicing their own concerns about issues. And they're not free from overwork, because overwork is a very strong characterization of the life of people who have full-time employment, who are not blue-collar workers, but in fact are what we call white-collar workers. And they have long hours. They oftentimes work 50 hours or more per week. And there are a number of publications from the ILO and others that show the more hours you work per week, the more your risk of hypertension and cardiovascular diseases. So we want the workplace to be healthy, but we want workers to be able to also leave their job and spend time with their family, to be a family member. We urge that people be free to thrive, that they be treated with respect and fairness, a living wage, so that they can support their families. We want a commitment on the part of our society to healthy work as part of our future. So making a commitment to healthy work requires that we start by assessing whether we have a healthy work environment. So we want workplaces basically to commit to doing an annual survey of the work stressors, to use our survey to see whether or not there are an increase in work stressors according to the workforce, so that this information can be used to guide our efforts, okay, to improve working conditions and optimize worker health performance and retention. So how are we going to go about doing this? Okay, well, we want to know whether or not the workplace is healthy. We got to measure it. So we've created a survey, the Healthy Work Survey, which is intended to measure psychosocial hazards of the workplace, what we call work stress, both for individuals and on organizations. And we want to create scientific scores that can be compared to national averages. So we borrowed some of the items from the NIOSH Quality of Work Life Survey to create our Healthy Work Survey, so that when we get a result, we can compare it to what NIOSH's standards are, the NIOSH results are, so that we can say, okay, this workplace or this individual is doing better or worse than the typical person of similar background in the United States, which is the data that NIOSH is collecting. So we have a report that can be done for individuals. They can go online and answer it and get results within a few minutes of answering the survey. And I'll show you what the survey looks like in a moment. The good thing about this is it's free. It's been created by the Center for Social Epidemiology for public use. We're not charging for it. And it doesn't take long to fill out, just 15 minutes. And we have assured that it's anonymous and it's secure and confidential, so that people can answer it without fear of any consequences for misuse of the survey by anybody else. So what does it measure? We measure the same stressors that we were talking about above earlier in our presentation. We want to look at demands and control and rewards, work arrangements, whether or not they have precarious employment or not, the level of supervisor and coworker support they're experiencing, whether there's issues of work-life balance or imbalance, whether they're subjected to emotional labor or workplace injustice. And then for the physical environment, we want to know that it's safe for the workers. Is there a good safety climate? We believe that's important. What impact has there been from COVID-19 at the workplace? We ask questions about that. And then we ask them about their self-reported health. So what happens with the survey? You come to our website. If you're an individual, you can find a link that allows you to answer the survey, and you will get an almost immediate response as the computer simply processes your response and sends you the results shortly after, within a minute or two of the time you complete the survey. And you will have the results that I'm about to show you for groups as well as for individuals. And we recommend that if the survey is being done for organizations, that they aim for 60% participation rates, so that they can be fairly sure that there's no systematic bias in the data that's being collected. And they will receive an aggregated report within 1 to 2 days as the computer, generates what I'm going to show you in just a moment. And these results can be compared to the national sample. And we urge that the results be shared with all levels of the organization. So what's in the report? So here's the front page, the first page of the report, showing some of the results for an organization in terms of the psychosocial hazards that we're measuring. And you see the first box on the left. We have work demands, we have job control, emotional labor as examples of workplace stressors, work stressors. And we also are assessing workplace justice, feelings of discrimination. And the next two boxes on the right, they have nothing under them, but we do ask for about physical hazards and work arrangements. And in this particular survey, this workplace didn't have anything to report that was abnormal on those topics. And then finally below, we also ask about precarious employment, the COVID-19 impacts, the health status, of the individual, including their mental health, whether they have depression and burnout and sleep problems, etc. So then the next part of the report will show you scores, okay, on different work stressors. So this table shows you the results for high demands. You see the U.S. average from the NIOSH Quality Work Life Survey is 6.1. Well, this group that answered this survey, the group average was 7.1, and this put them into the high risk category. And similarly, for all these other stressors, we can characterize whether or not they are above or below the national averages. Now, the red bar on the far right-hand side is telling you whether or not for any particular exposure, the group is above average. And you'll see mostly that they're red bars, that they're above average. Keep in mind that workplaces and individuals who are filling out the survey may be doing so, in fact, because they're experiencing stress. So we expect their scores to be higher. This is not necessarily going to apply to every workplace that fills out the survey. So what do we do with this information? What can organizations do, okay, about their workplace? So as the figure that we said about the things, the goals, we want each workplace to commit to annual assessment, because without knowing whether or not your workforce is exposed and what level of exposure they have, there's really not much that workplaces can do. So you need to make a commitment to assessment of the workplace. And then along with that commitment to assessment, you have to ask yourself, is your company, is your workplace ready to do change? Okay, or is the management and the staff and the union and whoever is the participants in the particular workplace, are they committed to change? And then once you do the survey, you need to share the results with every aspect of the organization, all levels, especially the employees, to get feedback from the working people. And then once you try and prioritize one or two major issues, don't try and do everything. Do something. The worst thing that can happen is to do a survey and not do anything. Okay, that will cause very bad feelings among working people in general, and it will not lead to any positive change. So there are other strategies that one can use. The survey is a starting point, but then you may say to yourself, well, the survey says we have this problem, that problem. So on our website at healthywork.org, we have all sorts of work stressors, strategy interventions that we have developed and which are on the website. More than 30 case reports that show strategies that help to reduce work stressors in various organizations. We have interventions for reducing bullying, for improving job control, or assessing and addressing sexual harassment and violence at the workplace. So the overall goal of the Healthy Work campaign, we know that psychosocial work stressors are getting worse and that they're impacting on the health of workers, vulnerable workers, and making their health problems worse, and that this problem in general is being ignored. We have stress at work increasing injuries, accidents, disability from all sorts of causes, including depression and hypertension and CVD. And the cost to businesses are enormous. Hundreds of billions of dollars a year, reflected in increased sick leave and absenteeism, decreased productivity, health and worker compensation premium increases for health insurance. Companies are paying for all of this, and they're not appreciating that much of these costs could be prevented by changes in work organization. So we need to think about approaches at various different levels, okay? Obviously, national standards from OSHA as to what is a safe set of workplace conditions is a goal, but we can use laws at the national, in addition to the national, state and local level, workplace partnership research, and work stress assessment tools like our Healthy Work Survey. And we need a public health movement, such as our Healthy Work campaign, to raise awareness that we are dealing with very serious problems that are taking their toll on working people. So the Healthy Work campaign provides a science-based framework for organizations. We're assessing workplace stressors and resources to reduce stress at work. And this can be done through work organizational change, job redesign, etc. And then thanks to our team members who couldn't be here at the presentation today, including Marnie Dobson, who helped with this presentation. And that's it. Thank you.
Thank you so much, Peter. That was an excellent presentation. And obviously there has been great interest in your talk today with 196 participants sitting in on it. It's a record for us. And I do want to start with the Q&A. And I have tracked the many questions that have been submitted here. And I'm going to group them. And it seems like there's a great deal of interest in the survey. So let me just ask some practical questions about the survey, since those could easily be immediately applied through your guidance. And so the first practical question is the Healthy Work Survey also available in different languages?
Yes, yes and no.
Okay, help us here.
We are working on a Spanish version of it. We have translated the entire survey into Spanish. We have, some resource limitations, okay? And we have competing interests. So we are, I would say, about halfway towards having a survey in Spanish. I would remind the audience that if they are looking for a survey, they might also explore I think there's 17 countries right now worldwide who are using a survey that's similar in theory, if not in terms of its exact content. And there is other in US,
Okay, I found this on the web in terms of its.
Excuse me, but my iPad wants to participate in this conversation. Let me tell it it's not acceptable for it to just jump in here and make a response. Okay, so there are other surveys. There's 6 or 7 of them in South America. Colombia, all of them are Spanish versions, and they may have some usability depending upon what the audience's purpose is.
Okay, so I guess people will be looking forward to being able to get it in different languages. That would be great, and we can keep people informed of your progress there. Let me ask another question. What's the ideal sample size for a survey if somebody wanted to conduct that survey in their organization? Any suggestions?
The more the better.
More the better, over 100?
Well, the best way to answer that question is in terms of the specific organization, okay? As an epidemiologist, we'd like to say we want to see 50 to 60% participation rates in workplaces to get what we feel are valid and unbiased results. So there's a very big difference between doing a group investigation versus someone going online to our website and answering the questionnaire as an individual, which will tell them what their own individual exposures are. So if you have a small workplace, then you don't need as many people. But if you have 1,000-person workplace, you should be shooting for 500, 600, 700 per, and those are not easy numbers to get. As anybody who's done any work in this area knows, you have to go out and, encourage participation and follow up. But I would say 50% would be a good number. And of course, if you can redo the survey again, that will increase your likelihood of having valid results. If you can compare two different attempts at answering the questionnaire.
Great. And how do you disseminate this? How is the survey disseminated? How do people find out about it? Is it solely through your organization, or is there some central place that people can go to?
Well, the website that holds all of this material that we're talking about is healthywork.org. And I think if anybody's listening, just writing down or remembering Healthy Work will get you to our survey. There are other surveys, and our survey is listed along with those, like the NIOSH WellBQ survey, which has a different intent to what we're doing, but it's still a valuable survey and will give important information about the work organization and work environment. And then NIOSH and OSHA and many websites, centers of excellence all across the country have our survey, with information about it so that people can find it. But as I said, Healthy Work, that's just need to know the word Healthy Work, and you will find the survey.
So one suggestion is to do it through employer organizations, making them aware of it.
We would be very happy to do that, but it's been much easier to get worker organizations, occupational health groups and unions and labor groups to answer the survey. Businesses have been rather slow. We have had a number, but I wouldn't say we have an overwhelming response from businesses. And I would like someone to ask me the question why that might be true, okay? Instead of Christina running away from your questioning. But it's a good thing to hear as to why we're not getting a good response from workplaces.
Well, that is a very good question. And I was wondering if there are any success stories that you can share in terms of a company actually committing to it on the basis of finding out results from your survey.
We have done a number of workplaces. They're usually fairly small businesses as opposed to large ones, but we just are finishing the Yolo County Health workforce of almost 550 people, and we have measured their stressors twice with the cooperation of the administration in Yolo County, and we have extensive data which we will be publishing hopefully in the near future. It is difficult, okay, to get companies to, I think, take a substantial risk is the way I see it, as to getting the companies lined up to get their workers. We've worked through some of our labor organizations. People who are listening in may know David LeGrand, who is the director of OSHA's, the Occupational Health Office of the CWA. And we have worked with a number of CWA-related organizations to do surveys, but those have been mostly smaller groups.
And is it possible to have the data de-identified so that researchers can analyze it in various ways, and can comparisons be made relative to related industries, or is it just compared to all organizations?
Well, as everyone who's listening to this can imagine, our fond hope is that over time we will get a number of workplaces to repeat the survey so we could look at longitudinal change. But we have also gone to extraordinary lengths to de-identify and securitize this information. And there is no way for any individual to answer the survey and have this information obtained by their workplace. They can get back a report, but there's nothing that on the report other than the fact that it's come to them, to their email address, that will tell them, okay, that where this data has come from and who is associated with it. And we've done similar things with the groups, organization groups that have answered the survey. It's a trade-off because we have less control over how to use the data from a predictive perspective, but I think the safety of the participants has been a priority.
So there are still other questions about your survey, and in the interest of time, I want to broaden the questions to things that you said earlier in your presentation that people are curious about. Are there unique hazards for women? You did include women in your data set when you conducted your studies, but is there anything you can call out as unique hazards for women versus men?
I'm not ready really to answer that question at the moment, okay?
Okay.
Not a lot of differences for most of the exposures, but there are some that people do know about. I mean, there is gender differences in terms of exposure to certain variables, including job strain and effort reward imbalance. But I would be more than happy to send you a quick summary of all the differences that you can distribute to anybody who would like to see it. I don't think that we have dramatic differences by gender, okay? By age, yes, okay? The longer you're at work, the more stress people are reporting, unfortunately, but not terribly surprisingly.
So a person has asked, what are some research opportunities for medical students in working with your center? Is there any avenue for people to be working with you?
We are prepared to work with interns, and students, but we don't have funding for them at the moment. So they would have to come with some sponsor, but we would be more than happy to, have them participate in our activities.
Great. And, you did present a lot of information about blood pressure. A question came in about other indicators of job strain, such as cortisol. Would there be other indicators that you'd want to track as well?
Well, if you're trying to have a fuller understanding of the etiology of some of these health outcomes, such as hypertension and coronary artery disease, obviously the intermediate variables are important. But in terms of identifying populations at risk, okay, I don't think we need to draw epinephrine and cortisol levels from individuals. We know that those things are all fluctuating consistently with the arousals, the exposure variables, and if your blood pressure is up, almost surely a number of these other variables are abnormal at the same time. And there was just a publication this week saying that high blood pressure is turning out to be the single most important risk factor for health outcomes in the world. Even more important than coronary artery disease, as hypertension is an enormous contributor to all of these different health outcomes. You don't need cortisol and epinephrine levels. You just need a good way of measuring blood pressure. And so let me just say that casual blood pressures taken in a doctor's office are the last measure that you want to use for trying to understand what's going on, because they're so variable in response to both the individual's anxieties and needs and the processes and the procedures that go on in the doctor's office. There's a huge body of literature that complements the causation argument that shows that ambulatory blood pressures get different results when people wear them and to work, which is our initial study results from the Cornell study that I started with Dr. Tom Pickering. And I started with Tom Pickering, and the audience should know that because Tom's not here, but he developed ambulatory blood pressure monitoring. And that's what made this initial work on the causes of hypertension possible, because we were able to study people in the work environment in 1985. You couldn't do that 2 or 3 years before that. It was an enormous change in protocol, and it really led to a lot of important findings, not the least of which is people who go to the doctor's office and are told they have high blood pressure have a 50% chance that they don't have it, that their arousal, and the other 50% who don't have it have a substantial proportion of them who do have it, if you use work time ambulatory blood pressure.
Great, and I'm very happy that you mentioned Jeffrey Pfeffer's book, Dying for a Paycheck, and mentioning the statistic about 120,000 unnecessary deaths per year due to job strain and work-related factors, risk factors. That's a staggering number. And one question that always comes up is, has somebody done a cost-benefit analysis of reducing job strain in organizations to prove the concept you're better off as a business to address those factors that create job strain?
There's been some work in Europe that has attempted to do interventions more systematically. We have work going on in the centers of excellence, which are trying to do the same thing. And I think the results are consistent with the idea that if you reduce the stressor, you're going to reduce the outcome. So I think that there's a consistent body of evidence around this topic.
Yeah, it's just very hard to get the commitment to addressing these changes. And it sure would be great if we had some models to follow in terms of real successes. Many people have asked questions, which is wonderful, and we won't be able to get to all of them. And I would just suggest if you have specific questions about the survey or about the studies that have been presented by Dr. Schnall, that you contact him directly to ask those questions. And I believe everybody will have information in terms of how to contact you for this. There's tremendous interest here in what you've presented. And I apologize to all of you that I didn't get to your question here. Is there any parting shot that you want to make to the group now that we are close to the end of our session?
Yes, let me ask and answer a question, and then people can get back to me if they feel that what I just asked and answered is not. But when you look at all of this presentation, you have to ask yourself, why is it that there isn't being more done in the United States to prevent these unhealthy workplace factors from existence? And there's two major obstacles to progress in this area. Number one is the medical model that dominates our thinking about what is the causes of ill health and health outcomes. We have a philosophy in the United States that individuals are responsible for their own health outcome, and that they don't take proper care of themselves, and you get high blood pressure because you don't eat right, you don't exercise, you're overweight, et cetera, et cetera. And a role for the work environment has not been significantly entertained. And the other part of it is businesses are not particularly anxious to accept the notion that they're responsible for all of these health outcomes. There's a lot of evidence that they are, but they're reluctant to take it on, and they fight it tooth and nail, and they are supported by the medical profession, which doesn't argue that you're mistaken about this. So you have a very powerful alliance of social forces, of the medical profession and businesses. And I know I'm going to say something here that everyone will tell me I shouldn't have said, but they all both benefit from this hand-in-hand relationship, okay? And they're benefiting economically. So we need to understand that as to what's going on. OSHA is handicapped, okay, by strong political forces. There's no one who works at OSHA who doesn't think we should have a national standard around work stressors. At least I haven't heard anyone say, oh, you're off the boat here, Peter, this is ridiculous. Okay. Thank you, Christina.
Well, thank you, Peter, for your presentation today. It's been very, very successful by the comments that are coming through in the chat. Thank you so much for your time today. And thank you for joining from Bogota.
Thank you very much for the invite. I'm delighted. I'll be back.
Okay, thank you so much.
All right.
Back to
Thank
you,
you, Ed.
Michelle.
Thank you, Christina. Thank you, audience. Thank you for all those questions. Appreciate it.